good evening, everyone. My name is Ayat. I am one of the pediatric ST7 doing the STAR series. Um, Welcome for the fifth session of the STAR series organized by the British Sudanese Association of Child and Pediatric Health. I am very pleased to introduce Dr. Maha Gasmelseed, a consultant pediatrician. She will be speaking today with us about the safeguarding tips for the STAR assessment. A couple of tips regarding this session. This session will be recorded and it will be in the YouTube channel, and also the previous session will be with it. If you have any question, please feel free to unmute yourself and ask, or you put it on the chat and we can answer it. And also at the end, there is a feedback link. If you can fill it, we will be appreciated that. And you can put your all question in that feedback. The floor with you, Maha.
Thank you very much, Ayat. Hi, everyone. My name is Maha Gasmelseed. I'm a new pediatric consultant. I'm working currently in Hillingdon Hospital. I was working previously in Basingstoke Hospital. I had my CCT in 2023 and have been working as a consultant in general pediatrics with interest in high dependency and cardiology, as well as neonate. We are going to talk today about safeguarding station regarding the START assessment. My presentation today is based mainly on my previous experience doing my own START assessment, as well as my previous experience as a registrar as well as a consultant with safeguarding. That will be part of the session as interactive between me and you. So I would appreciate if you can put your camera on if you can. We are going to start now. So our objectives for this presentation, first we are going to do a quick overview for the START assessment. And secondly, we will talk about structure for answering safeguarding scenarios. And then at the end, we are going to discuss some examples for safeguarding scenarios in START assessment. For START overview and the structure of answering safeguarding scenario, that will be like a presentation from my side, but I would appreciate if we can make the examples part as interactive, so I can give you the question and then we can have the answers from your side. So regarding the START overview, I'm sure by now all of you know how many stations that you have in your START assessment. I just wanted to mention here, so for this safeguarding station, as well as most of the other station, you will have 4 minutes initially to read your scenario. This is definitely different in the safe prescribing station, where you have more time to prepare yourself. For these 4 minutes, I just want to say that you need to use these 4 minutes very carefully. So read the scenario very carefully, and then I think maybe my colleagues already mentioned that you need to have a structure for every of these stations in your mind already prepared before you start assessment. So try to integrate what you have in your scenario in the structure before going or before meeting with the assessor. Previously START assessment was face-to-face, but now or after COVID, it's now virtual assessment. So you will have the 4 minutes to read the scenario, and then you will move to speak to your examiner or assessor, sorry. So during these 4 minutes, you can, as I said, read the scenario and then have your structure. You can make also some notes, and then you can, you will go and present it to the assessor for 8 minutes. And I think this tip is very useful, where people say, don't stop speaking. So yeah, use this 8 minutes just to speak over what you want to say. The more you use the 8 minutes, the less questions the assessor will ask you. And usually the assessor will ask whatever you didn't mention during your presentation or your answer. So try to use this 8 minutes fully, unless the examiner or the assessor stops you and ask any questions. Will be my tip for this one. I just want to go quickly through what you will be assessed on during start assessment, and I think most of you already know that. So these 6 domains are the area that you will be assessing most of all the scenarios. So decision making and priorities, knowledge, management of complexity, professional approach, safety and risk management, and then your communication. I wouldn't take much time to go through this, but you can find this in the RCPCH website. And then you will have the second one, which how you need to how you will reach well above expectation or perform as expected standard, and how to avoid further development or serious concern in every one of these domains. As regarding the safeguarding station, there are key domains that will be assessed. One of them is your clinical assessment and judgment. So the assessor needs to see that you identify, analyze the relevant safeguarding concerns, interpret clinical and social information to formulate risk. You need to demonstrate an awareness of threshold for child protection referrals. So you need to demonstrate this very clearly to your examiner while you are showing him your answer or your structure of the answer. The second domain to be assessed in safeguarding station is your decision making and management planning. So the examiner or the assessor wants to see that you have a very clear plan of management for that specific child, and you have very good understanding of who you want to involve in that scenario and how you will go forward with that specific clinical presentation. The third one is your communication and interpersonal skills. So that will be very clear in your communication with your assessor. So make sure you have a very good body language with eye-to-eye contact, and your communication, verbal, I mean, communication is very clear. Also, while you are mentioning your management plan for that specific scenario, if you have any part of your scenario saying that I will, for example, inform parents about my concern, about my safeguarding concern about this child, try to demonstrate to the examiner or to the assessor how would you communicate. So you can just mention, for example, I will introduce myself initially. I will be very sensible. I wouldn't be. I would be in an unblaming manner. I will explain to them that we are doing all of this because the child is our priority. So while you are saying your plan of management, try to demonstrate how would you communicate with parents, for example, or how would you communicate with the other multidisciplinary team members if you are involved in, for example, the orthopedic team or the ophthalmology team or any other teams in your management. So if you demonstrate that will show how well you communicate. And then teamworking and leadership, as I said, you will definitely in safeguarding scenario will need a multidisciplinary team approach. And by mentioning these team members and how you communicate and what will be the use of them, that will demonstrate your teamworking and your leadership in these scenarios. Professionalism and ethical practice, that will be also reflected during as a knowledge of what steps you need to manage during the scenario. And then knowledge of guideline and legal frameworks will come at the end, as I said, for your further plans after managing the child and follow-up. So these are the main domain to concentrate on for your safeguarding scenario. And then when you have the assessment, you will receive a feedback after your assessment. And the feedback, as I said, will be your either um, performed well above the expectation, or you performed at the expected level, or you need development. And very, very, very rarely there are concerns. For most of the candidates, they can have the needs development, or development is needed. They will mention some of these recommendations to be done. For example, you need to do a safeguarding CBD with your clinical supervisor or one of the consultants. You need to do a trust training. You need to do one of these courses. My advice would be, whenever if you receive any of this feedback that you need to do one of these courses or one of these recommendations, please book it immediately after the feedback, because you need to demonstrate to your ARCP panel that you already took this recommendation seriously, and you already acted on that. So that will be useful for your ARCP assessment before your CCT. Of course, after your start feedback, you will have your start PDB, and then one of those will be, for example, if you have any needs developing in one of the station, one of the PDB will be like, I need to do a safeguarding CBD, and then when you do it, you need to link it to your start PDB. So that would be important. And then, as I said, there should be, or you should prepare a structure for your answer for every station in your start assessment. And the structure for safeguarding, I mean, for most of them, the structure will be almost similar, but this is what I suggest as a structure for answering your safeguarding question. Um, so the first one will be, you need to read the scenario, as I said, very carefully in these 4 minutes. And if you already have the structure, just write it down and try to memorize the important parts of your structure, and then try to write the part of the scenario that you want to write in your structure. And then after you have the structure, you need to mention first your patient safety. So patient safety would be your priority in every station, and that either if the patient, for example, you will see in one of the scenarios or one of the examples we will mention later, that one of the patient, for example, has bronchiolitis at the same time, and he needed oxygen. So one of the things that you need to mention is how to manage his clinical condition. So don't concentrate only on the safeguarding part of the scenario. Also manage the child clinically would be very important, because if the child needs oxygen and you proceed with the safeguarding, then the child safety is not your priority. And then as a senior registrar, you will concentrate mainly on the safeguarding protocol and the assessment history and examination. But as a consultant, you need to think widely. So you need to think about the whole department and how you would manage, because this case, maybe you will have the case while you are consultant of the week, or while you are covering PAU, or while you are, for example, the neonatal consultant. So you could maybe you are busy at the same time managing a very serious patient in high dependency unit. So you need to mention, I need to have the department safe. I may ask help of one of my colleagues to cover the case of the safeguarding, and then I can continue with the ward round, or assessing critically ill patients. Um, so that would be important. And then the next step is to check the background. So before entering the room where you have parents or carers and the child sitting, you need to quickly go to the electronic records and check if there was a previous safeguarding admission, or if there are any previous safeguarding concerns about that child. And also you may need to call, for example, the social duty worker, and ask about the background of the family, because that will be a red flag in your assessment, and that may guide you further for the management for that child. So checking background before your assessment for that specific child is really important. And then you will go through all the steps you already know about safeguarding protocol. So you will print the safeguarding pro forma, and then you will take a very detailed history. You know, the history of safeguarding is very important, and very similar to the history that we are taking usually for other children. The important part of the history in safeguarding is the social part, and I think that would be mentioned in all your guidelines for safeguarding. For example, there is part of the social history where you need to ask parents about their alcohol and substance abuse. You need to ask them if they have any previous contact with police. You need to ask them if they have any domestic abuse history in the family. You need to ask for both of them if they have any involvement with the social team, even when they are children. So I think that part of the history is very important, and you will I'm sure you will find that part printed in your safeguarding protocol or safeguarding pro forma. I forgot to mention, before taking the history or before starting the history, preparing yourself for the history and examination, you need to take a camera or an iPad, which usually link to your hospital, I mean system, where you can upload photos for that child. And you also need to take a tape. So the tape will be very useful in measuring the bruises or whatever the presentation is. So taking iPad and a tape is very useful. And also you need someone with you, so you need at least a nurse to be there before you go to the room, or maybe another doctor, either a senior house officer or a registrar. For some of the scenarios, social workers and police will be already there, so they can attend. They can attend part of mostly the history and part of the examination. Or sometimes they can attend the whole history and examination part. You also need the consent of parents. So there will be one of the documents in the safeguarding pro forma will be consent. So make sure before taking any history or examination that parents or whoever has the parental responsibility sign that consent for you before proceeding. So these steps are very important before proceeding into history and examination. So you completed your history and you completed your examination. Of course, the body map is very important. You need to document very carefully, writing the side of the lesion, writing the size of the lesion, the color of the lesion, and what do you think, if it is a skin rash, or do you think it's a bruise, or do you think it's a significant mark, and describe the lesion very carefully. And then at the end, you need to give a very brief provisional diagnosis or impression, and that will be guided by your background check and also by your history and examination. If you have a lot of red flags, or for example multiple bruises in a child who is less than 1 year old, then you will suspect this is most likely an accidental injury, or at least you can write non-accidental injury cannot be ruled out. And then you want to do further investigations, which I'm sure all of you know, which is most likely blood investigations to rule out any bleeding disorder or vitamin D deficiency in case of fractures. And then you will proceed with CT scans and skeletal surveys and ophthalmology reviews if required. So this will be the most likely scenario. that you will go through. After you finish all this, you need to think about who needs to be involved in your scenario. For example, the scenario I just mentioned with the bruises, you already did your blood investigation. If there is any blood abnormality or result abnormality, you may need to involve the hematologist, for example. And if the all coagulation are normal, then you will need to involve the ophthalmologist to look at the back of the eye to rule out any hemorrhages. And then of course, you need to involve the radiologist to discuss the skeletal survey and the CT scan request, and then results or reports after. Part of the MDT could be the orthopedic team if in case of fractures. And of course, you need to involve the safeguarding team and the social team in your scenario. You may also involve the safeguarding lead if you have any doubt or anything that you are not sure about. But for most of the cases, you go and speak to the safeguarding team. We usually involve the safeguarding lead if we have any doubt, as I said, or if you feel like this case most likely will go to court. So you will need advice how to write the report and what do you need to mention in the report. And then after yes,
there is one question in the chat.
Yes.
From Saifuddin, he asked, can I ask the social worker or the police not to attend at the time I am doing the child protection medical, as one consultant suggested that before in our discussion?
So my question will be, why you want them not to attend? Because for most of the scenarios, you need to ask parents. So it will, yeah, if I would say if parents are happy for them to be present, then I prefer for them to be present. I think from the legal point of view, and then they will hear all the answers for your questions. The only the only part I will be more cautious about examining the child is a little bit tricky, but as I said, if parents are happy for them to be present during examination, I wouldn't mind that. So yeah, after taking the consent from parents, you can ask them about the attendance of social worker and police. And for all the cases I did, they were present and parents were very happy for their present. All right, so we said after you have done everything, you will have the results and the... Any other questions, Ayat?
No, he said, Saifuddin, he said the consultant said the social worker might make it less convenient by imposing the pressure. I don't
Yeah,
think
yeah, I mean, it's a good point, I would say, but yeah, I feel their presence is more supportive from my side, and usually, as I said, if parents agrees, then there wouldn't be a lot of problem, and they will stay at the side of the room, and you will be leading the scenario, so they will be a little bit away from facing parents. But as I said, options will be for parents, I would say. So yeah, you have your results from the CT scan, from the ophthalmology review, from the skeletal survey, and then you have your strategy meeting initially. For example, if you have multiple bruises and then rib fractures in your skeletal survey, and then this will guide you more towards non-accidental injury or child abuse. And then the police and the social team, together with the consultant who is dealing with the scenario, can have an agreement about what would be the next step of management. And then you need to mention at the end of each scenario that you will take this as opportunity of teaching to the department, either to the you discuss it in the consultant meeting if there is any challenging part of the scenario, or you can take it to the just regular meeting to registrars or senior house officers. So I think I would suggest this as structure of the safeguarding. Maybe I missed some of the things that important, but I think roughly that what you need to cover during your safeguarding station for your structure. I want here to show you an example. Maybe it's a little bit crowded, but this is how you want to prepare your structure. So if you can have similar structure for every station, yeah, already prepared before you start assessment. So you can see in this one, she wrote down that she wants to use the 4 minutes for her preparation, and then how patient safety will be the important, and then departmental safety, and then checking the background, and then she went through the safeguarding pro forma history examination, and siblings. Yeah, I forgot about siblings, so it's very important if there is siblings in the house, to inform social workers, especially if you have a very high suspicion of non-accidental injury. And then, as we said, you need to mention the investigation that you would like to do, and then involving the multidisciplinary team, whether that will be social service, safeguarding, police, orthopedic, hematology, or ophthalmology team. And then we spoke about how we need to discuss about the multidisciplinary team meetings, and then at the end, the follow-up, and then teaching for the department. So I think roughly if you can structure something similar, and just try to memorize it before you're safeguarding another station, I found that very useful in my start assessment. I just brought this one to give you an idea about your limitation. So if you face a scenario where there are difficult parents who are refusing to proceed with your history or examination, you need to mention there are specific protection orders where police can have a legal mechanism and keep the child in the hospital for 72 hours. So even if the patient refused to follow your history and examination, you can do the police protection order. There is also emergency protection order, which can be requested by the social worker or the social team, and they request that from the court, and that can be up to 8 days. The police protection order is only for 72 hours, but can be renewed. You need also to know about Section 47, and this usually when people are not very sure whether there is abuse and the extent of the abuse in the family. So that's kind of gathering information about the family. So I just wanted you to know there are a lot of other information that you may read about safeguarding, about other orders and other sections, but those I think are the most important bit. And yeah, as I said, you may face a scenario where parents are not very cooperative, but if you have any concern about the child, you just need to proceed. All right, so I think we can start now with our scenarios or example. Any of you would like to volunteer for this one?
You can unmute yourself.
Yes, I can be a candidate, sorry.
All right, Saifuddin. So you received a phone call from the consultant radiologist. Says she was reviewing a chest x-ray done a week ago and came across this chest x-ray who has a posterior fracture. Clinical information on the request is 2-month-old baby with query bronchiolitis. Baby was discharged home after 1 day stay in the hospital. How do you want to proceed with this scenario? Just roughly with the structure we just mentioned.
So from this structure, it looks like we are dealing with a serious medical emergency and safeguarding emergency, and that need to be dealt with immediately, involving the social workers and maybe later the police. I think this child should be admitted immediately to hospital. We should communicate that to parents gently, but at the same time clearly, that we are dealing with this. Admit the child, do safeguarding medical, and do all the assessment.
All right. Okay. Yeah. Perfect. Thank you, Sabaddin. Um, so yeah, what all you said is absolutely right. I just wanted to take all what we want to do in that structure I said before. So if we can go through that very quickly, I think that may be useful for this scenario, as you said. This is a very serious presentation with the posterior rib fracture is a very high indication for safeguarding or for child abuse. So the first thing, as I said, you need to mention that child safety is my priority. So you need to verbalize that to the assessor, that you are very concerned about this child and his safety is your priority. And then again, you are the consultant, this consultant radiologist called you, but you don't know what is your position at that time. Are you having clinic after 1 minute? Are you in the middle of your ward round? Are you in PAU dealing with a serious or a critical patient? So you just need to don't concentrate on the patient itself. Just think as a consultant more. So what I need to do to make the department safe, do I need to call one of my colleagues to deal with this and bring the child for assessment? Do we have a safeguarding consultant in the hospital who can deal with the scenario while I'm carrying on with my clinical job? So think widely about the department. And then after that, you need to check the background of the family. I know this is very straight, posterior rib fracture, 2-month-old, definitely safeguarding, definitely abuse, but at the same time, check the background of the family. You don't know if you will have, like, for example, the same family has another child who has a bone, congenital bone a problem. So check the background of the family, check the delivery of the patient, whether there was any problem during his delivery, using forceps or using whatever at his deliveries. So checking the background, whatever documented there, and also call the social worker to check the background of the family. And then, as we said, we will proceed with the history, very detailed history and examination, and then also checking if there is any other siblings in the family who will need to come and checked. So in this scenario, you will have the radiologist who called you concerned about the rib fracture. So again, I will definitely have a long talk with the radiologist about if there is any other concerns and if this rib fracture is causing any problem, any clinical problem for the lungs or any other concerns. I will definitely then proceed with the other investigation of CT scan and after a careful examination, CT scan, skeletal survey, and blood investigation mainly for vitamin D and parathyroid hormone and calcium level. And then you need to mention that you want to proceed with meeting with the social worker and police. And then you will have a very clear strategy meeting of what you will be in your next step of management after the results. And don't forget to mention that you will take this as opportunity for teaching in the department at the end of your scenario. We had a very similar case actually in the hospital, but that patient was admitted mainly, not admitted even. He just came to clinic with irritability, and the consultant who was dealing with him, and he wasn't gaining weight. So the consultant who was dealing with him, he just did everything so he will like tick all the boxes, and this posterior fracture came for him as a surprise. So yeah, this scenario was one of the scenarios mentioned in starting assessment, but it's actually, I would say, very common.
There is a question, Maha, before
Yes,
they mentioned, do we mention how to communicate with this with to the family? Because the
yes.
child is at home. How we will mention that? Because this is also my question. How we will call the parent? We will say to them clear it is we got a safeguarding concern or we got a rib fracture, or we just mention to them we want to review him. How we will communicate that to the family? Or we will social worker first, or what you advise?
Um, I think in this scenario, because the patient will be coming back to the hospital anyway, and we need to discuss it in details with the family and having their consent for history and examination. I would say in the phone that we discovered the fracture in the chest X-ray. We don't know what is the cause of that fracture, but we need to assess the child. We need to assess the child very carefully to look at other injuries. And when you come to the hospital, we will have a longer discussion about what could be the causes. So I will just leave it at open, but when they come to the hospital, I will be very clear with them that we have a very high suspicion of non-accidental injury because of the age of the child and because of the nature of the fracture. I wouldn't be very definite because, as I said, you don't know what is going on. You don't know what happened in the delivery. You don't know what result will come from the skeletal survey and the blood investigations. So you can't say it's definitely safeguarding, but it will be on the top of your list, I would say.
Maha, sorry, just a
Yes.
question. It was me who mentioned this. I mean, I came across a couple of patients, or in fact, parents who are quite sort of resistant to when you mention about safeguarding and, safety of the child. So, what would be your threshold here? Obviously, it's a 2-month-old to involve sort of, escalating it to police or social services immediately rather than just, because if you call them and if they say, oh no, the child is fine now, and they're not concerned, how would you approach, and what would be your threshold of escalating it? Like, I mean, I would escalate it then, to the police, and obviously if they don't want to come, I would just say, you need to bring the child to the hospital.
Yeah. Thank you, Said. Yeah, sorry, I think I wasn't very clear. So I would definitely escalate this from the beginning. So before even calling parents, I would already inform safeguarding team, and the safeguarding team in our
I
hospital
mean,
have.
you usually,
Yeah.
sorry to cut you. Like, if you are out of hours, so you're a consultant of the week,
Yes.
and it's a weekend, and if you are facing something like that, and there's no safeguarding team, so you definitely would escalate it, to the duty social services, and
Yes.
then if they want to involve the police, right?
Yeah. Yeah.
Yeah,
Definitely.
correct.
In
Thank
this
you. Thanks.
specific case, because there is
Of
high
course.
suspicion of non-accidental, I would
Yeah,
definitely
yeah.
involve the safeguarding team from the start. But as I said, there will be still no definite diagnosis unless we have all the results back, and then we will have the strategy meeting of how to proceed. Because I just wanted to mention that because we had one patient previously who presented, it was a very tricky case actually, presented to PAU with multiple bruises, and the child was also non-mobile. He was about 5 months old, and he presented with these bruises, which just started 2 weeks ago. And mom came and she said, I don't know what is the cause of this, and they were very multiple, like just covering that child. Yeah, dad just traveled to another country 1 day ago. So that was a suspicion that mom waited until dad went to bring the child to the hospital. So it was a very tricky situation. And then the team agreed to admit the child for query safeguarding and then do further investigations. But at the same time, they informed the social worker and police. And then the police came and arrested mom immediately. Uh, on that scenario, and then the next day, yeah, the dermatology team came and assessed the child, and then that was a different diagnosis for the bruises. So I think yeah, definitely involve them, but no shouldn't take any further step until all the team will be until the child would be assessed properly, and then taking further wait for the investigation result before any further steps, I would say.
There is a
Thank
couple of
you.
comments in the chat, Maha.
Yes.
Usman mentioned, do we need also to incident report the misfracture?
Because I don't know if it was missed, because It was mentioned that the X-ray was seen as for bronchiolitis, right?
Yeah,
Yeah, so
because
it was requested for bronchiolitis, and then the posterior rib fracture is not something that usually picked by junior doctors, and when the radiologist saw it, he immediately reported. So yeah, I don't think it was missed. I would say it's very difficult to assess for rib fracture, but you can consider that.
And Saifuddin, he mentioned, I believe in this case and generally in the safeguarding cases, the social service who lies with the police and involves them. I am not sure if we should speak to police directly or not.
Yeah, you are right. The social worker usually involve the police. We involve social worker and safeguarding, and then they will inform the police, unless we have like more concern to involve the police directly, or unless parents refuse to come as Sayed said.
Yeah, and the last question from Walid, if the parent brought the baby to the hospital and you need to admit the child, who will decide if the parent can stay with the child or not? It will be, I think, the social worker, yeah? Because after do strategy meeting or...
It is usually
Parents
social
always
services, isn't it? Yeah, they can
parents
have like
always stay.
supervised and stuff. Yeah.
No,
They can
parents
all-
always stay with their children unless the police arrested them, or there is an order from police for them not to contact their not to be in contact with their child.
Yeah.
So this is the usual scenario, unless there is something to say they are not allowed to come to the child, and that will be communicated from police to the nurse in charge and to us as consultants, and it will be very clearly documented in the child notes. But the usual scenario, parents can stay with their child usually.
Yeah. And the second question from Walid, shall I inform the parent over the phone that we have a safeguarding concern, or only we can say we discover the fracture and we need to investigate more?
As I said, in this specific scenario, because he is coming back, I will leave the causes in general and until they come, and then I can talk to them face to face. I would say will be better.
Thank you so much, Maha.
Yeah.
Yeah.
And then I just wanted to bring this here because it's a very similar scenario. So you are a consultant performing an outpatient clinic. One of your teenage patients whom you see regarding his asthma tells you that his hand is still swollen and sore following an accident 1 week ago. You discover from his case notes that he attended the emergency department after his accident, that his hand was x-rayed, and that this was reported by the junior doctor in ED as being normal. He was sent home with analgesia and no follow-up. On checking his X-ray report, however, you find that the radiologist reported the presence of a fracture. Do you think this scenario is similar to the previous one, or what do you think in general? I guess want to see what do you think?
Hello, hi. Okay.
Hi, Iram. Yeah, go on.
Thank you very much for giving us this talk this evening. So in this case, I think you'd have to explore a little bit about how this teenager hurt his hand. I think priority here would be to make sure the patient is safe. So if there's a fracture, we need to make sure if there's anything that needs to be done medically for him. After doing that and after making sure he's okay, you'd have to then do duty of candor and apologize to them. You would need to possibly put in a datix, and then look at maybe speaking to the junior doctor that reviewed the ED and see if there's any opportunity for the junior doctor to just sit down with him and explore what the issue was, how come the fracture was missed, and just understand the experience of the junior doctor, because maybe it's a very junior doctor. And then I would, at the same time, offer to do a case-based discussion with the junior doctor. I would then maybe, I would probably speak to the educational supervisor. It would be important, I think, to understand fully the mechanism of this injury that the teenager has had. I think depending on what response you get, you would then see if you would need to escalate it and go down the safeguarding pathway, is what I think, but I don't know if that's right.
No, I think you are absolutely right. This was a safeguarding scenario, so it's more about the safeguarding concern rather than the missing fracture in the X-ray. So yeah, I think what you said is absolutely right. But I will be less concerned in this scenario than the 2-month-old who we missed a posterior fracture. I think in this case there is a very high possibility this is an accidental injury. But again, I think answering this scenario would be very similar, as Iram said. Going through the patient safety is your priority again. You want to be sure the department is safe again, taking very detailed history about the mechanism of injury, how that happened. You need parents to be around. He's only 13, I think he's a teenager, or 13 to 14, so you still need one of the parents to be around before taking any history or examination. And then proceed if you want to do any further investigations for this child. And as Iram said, you need to report an incident and inform parents about the missing fracture. But I would definitely be less concerned about this child, and I will definitely not involve social team and safeguarding team immediately in this case. That's the difference between when you have very high suspicion and then when you are not very sure or you are not very concerned. All right, and then the second example,
regarding that, there is a couple of comments in the chat.
Yeah.
Seferdin, he mentioned, I feel it is less difficult here as the child can disclose the etiology and less lab capacity.
Yeah, you are right. Yeah, because that the teenager can give you the cause of the injury, but sometimes they may not tell the truth or be afraid or try to just hide what their parents did. So
yeah, and also there is a suggestion I would also mention about making a quality improvement project from this case. How can radiology department communicate better with other doctors about formal X-ray so it will be escalated as needed?
Yeah, very good suggestion. Yeah.
Go
Anything
ahead.
else?
No, yeah,
No.
you can, yeah, carry on.
All right, example 2. So this is a straightforward bruises or bruising so in soft tissue for 3 years old, admitted with prolonged febrile seizures. So who want to proceed with this one?
Okay, I can do it if it's all right.
Yes, Walid, yeah.
Okay, so this is a 3-year-old child with a prolonged febrile seizure, has only bruise and soft tissue. So taking in mind the child is mobile, a 3-year-old child is mobile, and it depends on the location of this soft tissue. Is it because it's liable to have bruises over like common area like the shin of tibia, the elbow, and the child have play and fall. Add to this is the child has prolonged febrile seizure. Normally, it's not common to have bruise from the seizure itself, even though if it's prolonged, because normally if the child has seizure, the parent should aware how to put the child in safe manner to avoid any further injury during the seizure. But what I will go, if I have this child, I will just take it more deep, take more history about this bruise, the location of the bruise, the how long does this bruise happen, and then doing full examination for the child, background history of the family, involve the social services, just have a phone with them, ask if they have any concern regarding this family before. Is the child brought to the hospital immediately after having this prolonged seizure? If the parent raised the concern before about this bruise happen, or any clear explanation from where this boy got the seizure. And then if the child, because had prolonged febrile seizure, just to be child is safe, it's any medical background which can cause this soft tissue bruises, which could be some hematological disorder, some bleeding disorder, I will proceed with the full blood investigation as well. If there is any concern raised by the safeguarding the social service, or any this family there's any delay in presentation to the hospital, or any explanation is not matching with the location of the bruise or the scan, maybe I will consider, I will put one of my consideration is not the top priority, the safeguarding concern. And if I got this one, I will proceed in full safeguarding protocol after discussion with the parent, after getting consent from them. I will just be sure there's any other family members or another sibling at home. And then I will go through if the child needs some more blood investigation, if the soft tissue swelling, if there any fracture anywhere, he maybe needs skeletal survey, he may have ophthalmological review or CT if I have concern. And after that, I think he will have, if I decide the child from the start there is safeguarding concern and there is this explanation of the bruise is not matching with the child story. So I will be involved the multidisciplinary team, involving the orthopedic doctor if needed, the ophthalmological as well, as well as the neurology. Maybe to have just be sure that child is it febrile seizure, is it or something else need further investigation and management, because normally the febrile seizure is not as a typical one, is not will be prolonged and causing any harm to the child. Then depend on the child if he needs hospital admission or no, if he discuss with the social services, the child to be safe at home to be investigated more, or if the child is not be safe and the parent story is not consistent with what I have seen, I will just prefer to keep the child in the hospital, observing him some more after getting permission from the social service and discussion with them. And I think this is tricky situation a little bit. I think I will talk with the safeguarding lead, because if the child, he could have soft tissue swelling as soft tissue, sorry, bruise. So again, I will mention depend on the location and the age of the bruise, the color, and then we'll take it from there. I think that's what I will do.
Right. Thank you very much, Walid. Excellent. So, yeah, I agree with all the steps you said. I think in this scenario, it's not as straightforward. You have a 3 years old who has a bruise, which is very common, because he's a mobile child anyway. And then they mentioned about the prolonged febrile seizure. So be aware that they may distract you with the bruise away from the febrile seizure, prolonged febrile seizure. So they want you to mention that first. So they want you to mention that the child is your priority and you want to make sure he is safe. You are treating his prolonged febrile seizure, whatever the cause is, because this child maybe his glaucoma scale may be deteriorating, maybe he needs oxygen, maybe this is meningitis. You have a lot of differential in your child before before approaching this child. So I would say concentrate more at the beginning on the prolonged febrile seizure management and make sure the child is safe before proceeding with the bruising, especially the 3 years old. This bruise could be explained by any injury, and as you said, could be explained by the seizure itself if there is an injury while he was seizing. So always when there is bruise with something else, which is more concerning, concentrate on the management of the acute presentation first, and then keep the bruising as your second step of management. And the step of management of bruising, as Walid said, is very similar to the scenario we just said, of checking the background, which will give you a very good hint whether if this family, if there is red flag about the family itself, the family or not. And then when you take the history, you may already find the explanation of the bruise from one of the parents, and then you can stop it there. And then, as he said, you will go and examine the child, and then at the end you will proceed with safeguarding if you think it is a safeguarding case. But most likely in this scenario, the bruising will not be a big deal, but you need to mention all the steps. Does that make sense?
Sure.
Yeah. Anything else in this scenario? Any questions, Hayat?
There is no question in the
Yes, please, can I ask a question? This is
Yeah,
Ahmed.
please go ahead. Go ahead.
So it says here he was admitted with prolonged febrile seizure. Can I clarify from them is this a presentation now, or he was admitted and he is now not seizing? Because it will make a difference. Is he admitted and he is now controlled the seizure, or he came to us in seizure? Can I ask them if I need more
So
clarification?
Ahmed, I think these comments are written by people who had their start examination. So definitely in the scenario, we'll have more information than what I wrote here. So people are just remembering from their start assessment what came and then write very short about the presentation. But in your start assessment, they will give you all the relevant information. But even if they didn't give you enough information, you don't need to ask the assessor. You just need to act on what you have and give the assessor the steps of management, even if you don't know what will be the scenario, which scenario will be dealing with. So you can speak in, for example, if the seizures are already under control, controlling seizures will be my priority. If they are already under control, then I will proceed with history and examination for the bruise. But you need to mention prolonged febrile seizure, I think, in this scenario first before proceeding with the bruise.
Okay, thank you.
No problem. All right, the third example. So you are a pediatric consultant. Sorry. You are the pediatric consultant reviewing all surgical and orthopedic admissions. There is a 18-month-old female with proximal humeral fracture after falling down stairs. Who wants to go with this one?
Please unmute yourself and just start if you want to participate.
Can I do?
Yes.
Yes, go ahead.
Okay, so I will start by seeking more information from the orthopedic team about their consideration about the mechanism of injury. So if the history and from them, of course, is from orthopedic, but of course I will take the history, also detailed history from parents. I will ask social workers if they have any concern about the family, because also 18 months old with fracture here, it can be accidental, but also it can be non-accidental injury. And also if it's not non-accidental injury, it can be some sort of neglect, because she should be under observation of their parents at all time. So after seeking information, I will go through the second step, which is the patient safety. I will confirm that she is managed. I mean, she is already under the orthopedic team, but I will ask them if there is any further complication. Is there any other injury? Is she under surgical as well? Because of this falling downstairs, she might have other injury. Then I will take initiative for reviewing her X-rays and discussion with the radiologist about for example, if it's a spiral fracture, it's different from a fracture from this history falling down. Again, I will go to asking parents about the history, and I will see if this is consistent or not. I will escalate also to the safeguarding team, because sometimes they have more knowledge about the mechanism of injury and the height of steps, and they cannot result in this fracture or not. She might need some blood investigations as well if she has some vitamin D deficiency or problem in calcium or phosphate. It might be pathological fracture, and just falling down the stairs may precipitate this fracture. Also, I will take the initiative for teaching for our colleagues, maybe the registrar, if he wants to have a case-based discussion about this sort of scenario or safeguarding issues. Yeah, I believe that's it. I will do full examination as well for her to rule out any bruise or any other injuries in herself. I will ask if they have also sibling with any safeguarding issues. It will be a red flag actually if there is any problem in the family as well. I may take I don't know if 18 months can give the history, but sometimes they can be talking well enough to get history from them. I'm not sure, but yeah, just a trial. I will give a go for her.
Right.
Okay, yeah, thank you.
Thanks, Ahmed. Yeah, I think the scenario can be very benign, isn't it? Because 18-month she can already walk, and she can fall down the stairs even if parents had stair barrier, and at the same time it could be something else. So I think as Ahmed said, you need to, I think, to take this scenario again through your structure. Make sure the child is safe, and then start very detailed history about the mechanism of injury. And having the orthopedic team already involved will be very beneficial for you to demonstrate if they have any concern about the fracture and the mechanism of injury with the fracture. Usually we consult orthopedic team if we have a fracture for children, for young children, or very small children and infant, and we usually show them x-rays and the mechanism of action, and they are the one who guide us usually through the if the mechanism if injury is appropriate for this fracture or not, together with the radiology team, as Ahmed said. So I think the multidisciplinary team approach in this scenario is very vital, and this discussion between the three of us is very important to determine whether we need to go further with safeguarding consent or not. Again, with the background checking, because sometimes if you have a very concerning background, even if the mechanism of injury is appropriate, you may investigate anyway, especially if there is serious previous safeguarding concern with the family. And again, as Ahmed said, I think as a very minimal, I would do vitamin D and parathyroid hormone and calcium level after examining the child to be sure there is no bone abnormality or any signs of rickets in the case. Yeah, I think it could be because the person who mentioned this scenario, he mentioned that the management is usually conservative in this age, and she got well in the station. So I think you can take it either way, but if you go through the structure and say if the orthopedic and radiologist agree with the mechanism of action, mechanism of injury, then I don't need to proceed with safeguarding. It's already 8:06. I don't know if you want to proceed with other scenarios, or shall we just conclude the session? What do you think?
I think
Yes,
we can continue if
we
the people.
continue if you have time.
Yeah, no problem. So this one is you have a meeting with safeguarding nurse, failure to thrive for a 14-month-old. Mother thinks, query multiple allergies, but she did not attend any of the tests suggested, severely restricted diet, and seems unwell. So who wants to go with this one?
Anyone want to participate? Just unmute yourself and go ahead.
Okay. So yeah, neglect is always tricky. I understand your anxiety. It's very tricky for us as well. But yeah.
Can I talk about it or?
Yeah. Go ahead.
So for this scenario, I believe it can go to one of two ways. Actually, the first one, maybe mom is neglecting her, and this is safeguarding one. The other one, maybe she is just she doesn't know, and maybe she has false information from anyone else, or someone give her false information, and we need to sort it out. So I will go first for the first way. How to know how to differentiate between both? I believe we need more information. This information can be taken from mom herself, from dad if he's around, from other family members. And on the other hand, from social services, if she is known to social services, was she under any doctors before or any under social services for any reason? And sorry for that, before that, we need to confirm that she has failure to thrive. We'll take full detailed history. We'll take her measurements and see her red book and the growth charts to see if she is really failure to thrive. Also, we need to do assessment for her all nutritional status, not only the weight and head circumference, but also for any signs of neglect, like infection, fungal infection, or hair clothing. So I believe full examination, including hair clothing, hair cleanliness, like what we are doing in the CP medical. We'll see if there is any process or any any other sort of or any indication of any abuse. The other thing, we'll see her record about her other sibling, if there is any. So we'll see if they are suffering from the same issue or not. Because I believe they need also a review. We'll review her also immunization. If she, is mom neglecting everything for her, which will be toward this safeguarding concern. Of course, I need to involve more people in this scenario, like social services, like dietitian, like health visitor, because she's now 14 months, but at the beginning of her, after delivery, what has happened at that time? Was there any concern initially about her progress, her developmental assessment? I may ask some colleague for help if they have similar issues. I believe we should have some clinics dealing with failure to thrive. I will see if she's attending or not. Then I will see how she managed through the 14 months. Was she admitted before? Because it's less likely that she was totally fine until 14 months. Has she attended to GP, for example, seen through this time? So we need to access her record to see when and why she attended GP or she didn't attend any follow-up with him. If she attended hospital for any reason, we need to know what is the outcome of that. Has anyone picked up the failure to thrive earlier? Because it can't be all of a sudden she presented with failure to thrive. Then I believe she will need complete safeguarding pathway. I will explain to her and then proceed through the safeguarding steps, including, as I mentioned, full examination, CP medical escalation to, of course, the safeguarding nurse is already involved. So again, why she is involved in this situation? What was the indication for her discussion about this case? I mean, normally they don't go to safeguarding nurse unless there is an issue. So she should have more information that I may again or discuss with her. Then we'll see if it's safe for the child to stay with mom or not. Because if this is a neglect, I believe we should do a strategy meeting to see if the child is safe to go home, or we need maybe to keep in the hospital for some time and see again, can we discharge home or not? I believe she might need child protection like Section 47, but of course, it's depending upon the MDT discussion. Thank you.
Yeah, thank you, Ahmed. I
Can
do
I-
like your answers, Ahmed. You mention everything usually, but I think you take part of the history, jump to the examination, and part again to the history. So the assessor wants you to be like finish all the history, go to examination, and then management plan. But I think you got all the ideas yeah there. So as you said,
I can mention one thing, Maha.
Yeah.
What I like for Ahmed, the first thing he mentioned to confirm she's a failure to thrive, and this is the most important because we always forget that because they put it failure to thrive. We need just
Yeah.
to if she's
Confirm, yeah.
confirm failure to thrive.
Thank
Yes.
you.
So I think in this scenario, Ahmed, the first thing that we need to highlight in the scenario is the last bit, which is seems unwell. So this again as I mentioned, they want you to concentrate on the child first before mentioning any steps of management. So this child seems unwell. Why she is unwell? If there is any problems. So again, patient safety is your priority. You want to you want to make sure this child is now safe and there is no other clinical concerns apart from the failure to thrive. So always in the scenario, if there is something alarming apart from the safeguarding concern, please concentrate on that clinical part of the scenario and make sure you address it before you proceed with the safeguarding part. So failure to thrive is always a little bit tricky. So what you need to do, as we said previously, just go through your structure, check the background, as Ahmed said. So when you say background, you need to mention in the background that you wanted to you want to check with the GP, you want to check with the safeguarding nurse, you want to check with her parents, you want to check with the her records. So, and the background is very important in this child because she, how old is she? 18 months. You want to go back and see her growth charts and whether she was born with this centile or whether she dropped over centile. So you need to go back and check everything before proceeding. And then you come and take very specific history about her total intake per day, about other about her losses, whether she has vomiting, diarrhea, or polyuria, any causes that can cause her to not to gain weight, and then yeah, very detailed history about her nutrition and about any other associated medical problems, and then you proceed, as you said, with your investigations, examination first, and then investigations. And investigations are very important here. So you need to screen for celiac and thyroid function. You need to do a full blood count. You need to check her renal function, kidney function, and liver function. So a full baseline blood investigation to make sure there is no cause for her not to gain weight. This thing about multiple allergies, you need to explore more, whether you need to do further investigations or whether there is significant history for allergy. So yeah, after doing all of that, before we say this is definitely safeguarding, usually for failure to thrive, we usually admit the child to hospital, and by involving the dietitian, we put a very clear feeding plan, and then we monitor the weight very closely. If the child is gaining weight in the hospital, that may make the safeguarding concern very strong. So admission to hospital, even if the child well, is very important, I think, in this scenario, because we need to demonstrate that the child is gaining weight in the hospital, and when we followed that feeding plan, he gained weight and he or becoming more well than before, and his investigations are normalized. So I think admission is vital in this scenario, to compare that with what was done in home. Yeah, and when you take the history previously, I forgot to say, yeah, checking the background also, you can check about the mother herself, whether she's a young mother and whether she doesn't know how to care about this child. So sometimes the young mothers, or sometimes mothers who has learning difficulties, they have difficulty dealing with children, and those kind of mother would need more kind of support rather than raising their care as a red flag. And then after that, of course, there will be a multidisciplinary team about how to follow this child and what will be the next step of management. And again, you will take this an opportunity to teach your department about failure to thrive in general, or how to manage children with query neglect. Any questions? Anything in the chat, Aya? Sorry, I can't go there.
There is no question in the chat. Any
Yeah.
question, please unmute yourself.
No. And then 13 years old, admitted with acute hip pain after sport injury. X-ray revealed a foreign body in vagina. Nurses report dad is very close to child and does most of the talking, although mother also present. Anyone?
Anyone want to participate?
Okay, so in this scenario, we have two problems. So the first one is that the child admitted with acute hip pain, which again, you need to focus on initially, and then you need to proceed with this foreign body in her vagina, which is definitely a very significant safeguarding concern. So again, the child is your priority, and you want to make sure she is safe. So this child is definitely needs to be admitted to the ward, either to the gynae ward or to the pediatric ward for further investigations and management. You want to manage her acute pain, so you will give her painkillers. You will involve the orthopedic team to make sure her hip is normal and there is no concern about fracture or dislocation. Moving from there, you want to check her background and the background of this family, especially dad, if there is any previous concern about the family from the physical or sexual abuse point of view for both parents and the child. 13 years old, you can take the history directly from the child, or you can involve parents as well. So in these scenarios, you can ask the child if she wants to speak to you without her parents' presence, and then you can take someone with you and then take further history from the child, and then you need to document what the child said separately from the history taken from parents. Yeah, taking history is very important, whether there is any sexual history or relationship she has, and whether she has any problems previously, and if there is any hint in the history that can guide you why there is foreign body in her vagina. And then examination will be very important. Of course, as a pediatrician, you will proceed with clinical examination, but a specific examination for the forensic part, there will be a special team in the hospital who can carry that. In some of the hospital, the team will be outside, so you need to communicate with them to come and examine the child, and they can work out of hours. For example, in our hospital, there is a specific clinic covered by some of the consultant who has experience in examining concern about any sexual abuse. So you need to book the child for their clinic the next day. But I think most of the hospital, the team will be outside the hospital, and you need to call them to come and examine the child to assess for any signs of abuse. They also will take specimens for assessing the area. But from your side, you just need to demonstrate externally if there is any signs that you can see without deep examination. And then you will after the forensic examination, or after the examination by the specific team, then you will have the conclusion, and at that part you will have the discussion with the social team and the safeguarding team with whatever the results of that examination will be. And I think that would guide you of what will be the next step of management.
Would it be appropriate to just speak to the gynae team as well, to just get input from them?
Usually there is no one in the gynae team who can deal with sexual abuse, so that should be under the pediatric team. unless you have a concern about infection or pregnancy. Of course, sorry, I forgot to tell that we need to do a pregnancy test and also some baseline investigations in this child. But usually it's one of the pediatric team who should come and assess, not the gynae team, unless you
No,
have
I meant it will be the pediatric team that will be seeing, but getting advice or speaking to gynae, is that something, if you to say that, is that wrong or?
I would say maybe after the pediatric examination and assessment, maybe treating the foreign body in the vagina.
I think her laptop switched off. It was giving battery low.
I
Yeah,
think so.
battery died. Yeah.
Oh.
I
So
don't know, Ayat, from your experience, or maybe someone else can answer. How about male children presented with sexual abuse allegations? Is any specific team allocated for that, or is it the same team as above?
I think if there's concern of sexual abuse, there's usually, so in London here, we would normally just refer to the Haven, where they do all the investigations and examination and take specimens for sexual abuse. So I think it would be the same team for male and female, but I'm not 100% sure.
In our trust, we have a special sexual team. It is not in the hospital. It is in the West Midland. It is like Walsall. You need to contact them. We are not dealing with the sexual cases.
It is called SARC team.
Yeah, SARC team. Yeah.
SARC team, yeah. It is a specific center for sexual assault referral. It's called Sexual Assault Referral System Centers.
Yeah.
Yeah, that's correct. Yeah, this is the team.
But
usually
that was a question about the gynae team before my battery died. Who was that? I can't remember now.
Welcome, Maha, back.
Yeah, thanks.
Yeah. They just ask about who should do the child medical case of the sexual abuse. It is the general gynecology in duty or a specific team, and also if it is about like male or boy sexual abuse, it will be who. We just answer it is in our trust. It is the SARC team. It is the sexual abuse team. What do you think, Maha?
So as I said, I think it's a joint between us as a pediatrician and the other team, because for this child, for example, you will proceed with the safeguarding history and examination, but the specific examination for the for the sexual abuse will be carried by that specific team, if that makes sense.
My question was about what if it is a boy? Is it the same team? And I think they said yes.
Yes. But yeah, I mean the safeguarding history and examination will be between the pediatric and the SARC team for both girls and boys. Yeah, sorry. For the scenario when we said about the foreign body in the vagina, we talked about the assessment by the pediatric team or the SARC team. But I think we may involve the gynae team in the management of the foreign body at the end. So I think you are right. We need to involve them, but for the management rather for assessing.
Yeah, thank you very much.
can I ask about mental health team in this case? Because we face some kids who are coming with the mental health disorder with doing this kind of thing for themselves. Is any rule for mental health cases in this case if you have 13-year-old girl with the foreign body?
I think definitely, yes, if you have this history of people are doing, or there is a previous history for that specific patient of doing this for herself, but before that, you definitely need a very detailed safeguarding history and examination and multidisciplinary team approach. But yeah, I think involving the psychology team is very reasonable.
Thank you.
I don't think I can share my screen. You need to make me a host again.
Yes, let me make you host. Yeah, try now if you can share it, Maha.
Yes. Do you see that?
Yeah.
Yeah. So 13 years old brought to ED unconscious after consuming alcohol. She was found unconscious near a park and brought by paramedic crew. Mother informed and is on her way. She had similar episode in the past when she was brought unconscious in ED. You are the consultant on call, and how will you manage the girl? Again, this is very common scenario. You have a lot of children who is coming or who are found alcoholic in the street at this age. Anyone wants to take this?
If no one, I can do it.
Yeah.
Yeah, so first of all, 13-year-old girl brought to ED unconscious. First of all, patient safety is my priority. I will take it for the ED. I will deal her first of all as unconscious parent. I will go through the APLS as ABCD.
Mhm.
And just be sure she doesn't have any problem with her airway, with her cardiovascular circulation, and then depend on what type of alcohol. If I can figure out what type of alcohol, I will go for the tox phase as well. And if she need any further investigation or medication, once I be sure this girl is her or you need involvement of any further anyone else because she found in the park unconstant, this she need further image or depend on her examination and what the story and definitely she will need hospital admission in the hospital to be sure she is safe and plus she is back to her conscious. We'll keep an eye on her glascoma scale. We'll escalate according to her response to the management and what do you think about her situation. Second of all, 13-year-old girl, once she is back to her, I will just figure out how she was born in the park on her own and what is the situation they found her on and because there's any harm for her, any abuse because she found in the park, anyone had her or anyone who gave her this alcohol. And then I will go through the social service. I would call them to discuss this case with them. Is this parent known to the social service before? Any safeguarding concern? And uh, and then I will, if the girl back to her normal, I will have a chat with her, just ask her about what's happened exactly, and this is the first time she had alcohol. This is to have alcohol or no, and then I will go through thorough examination to her with her from toe to nail, and then if any safeguarding concern about the neglect or bring the for 13-year-old girl, I would think maybe I'll consider safeguarding concern. It could be still one of the possibility. Other possibility could be 13-year-old girl who she's trying to take an alcohol, which could happen. So and then I will keep the child in the hospital and sorry the girl in the hospital until be sure she is safe. I will be sure there's if any other sibling around, they have any previous history of similar condition or previous history of any safeguarding concern for other kids at home or domestic abuse at house. And then I would discuss with my consultant, I think my senior consultant or the safeguarding consultant, as well as social service, because it's tricky situation. We need just be to figure out if there is any safeguarding concern regarding this girl after be sure she is medically fit. Um, and then I think I will do it in this way. I'm not sure.
Thank you. Thank you very much, Walid. Yeah, I think concentrating on having unconscious is very important, as you said, and start with that one first to manage her as unconscious patient, and you want to make sure that she is safe. So once you cover that, then you proceed with the safeguarding part of the scenario. most of these children who come consuming alcohol, they would have other substance abuse, or at least sometime overdose. So you need to send some toxicology, blood to toxicology to figure out if there is any other medications or substance that in her blood. And another thing that also remember in this tricky age, also to do a pregnancy test, because that could be the cause why she's drinking or consuming more alcohol than normal. So I think otherwise you will proceed, as you said, with the detailed history and examination. And then investigations, and then parents safeguarding, and don't forget camps will be very important in this scenario, because they need to discuss with the child, maybe not today, maybe the other next day, and they will be the one to clear her to go home if the safeguarding team found home is safe for her to go. But overall, I think, yeah, you just go similar to everything. Make sure you concentrate on the unconscious level or whatever mentioned clinically, and then proceed with safeguarding, and then don't forget the psychological or the psychiatric part of the scenario. Thanks, Walid. I need to go now. I have 2 further scenarios I may show you so you can do with your colleagues. This one says, you discussed the case of a 20 years old brought in by ambulance from home with her child who is 18-month-old. A neighbor intervened and broke down the door when he heard her screaming. The woman was assaulted by her partner, who hit her with a bottle and tried to strangle her in the presence of her son after she had been drinking, and the couple argued. They ran out of the door when the neighbor intervened. The woman was not found to be injured, neither was her son. When they were reviewed in ED, the woman declined referral to social services and did not want to report the incident to police. So I will if you can keep this and discuss it with your colleagues. I think the most important thing to say about this scenario, whatever the woman says, just bring the patient back and do full history and examination. It's not the choice for this mother, because there is a very clear history of insult. So you need to make sure this child is safe, and you need to do a very detailed assessment. Any questions?
Thank you very much, Maha. That's very useful.
Thank
Just
you.
for the start discussion, how far we are expected to go in the legal terms and police concepts in terms of Act 17, Act 47. I know we should know those 2 acts, but is there any further information we should explore and be aware of in the discussion?
I would say just have a baseline knowledge about those orders. Even us, sometimes we confuse between the orders, and we ask the safeguarding team if they said this child under 47, and can you remind me what is 47? And they say, like, we just need to collect more information. So I don't think the assessor will expect you to know all the details, but as I said, the scenario may be parents are refusing. They took their child out of the door. They don't want you to do any further investigation. So you can say that I know there are specific orders. We can we can discuss with the police whether they can do the police order to keep the child in the hospital for 72 hours, and I can proceed with my history examination and investigation. So you need to have the knowledge there are these orders around, and that you can take action against parents if they refuse to agree. But I don't think you need to know all the specific details.
Thank you. And also for the police order and emergency order, I think it's the social services, but we should suggest this in the strategy meeting, isn't it?
What do you mean? Sorry. Social
The
services do what?
police protection order and emergency protection board order.
Yeah, so the police protection order is usually by police. So the police will suggest this child needs a police protection order. For example, as I said, if parents are refusing to stay, the police can take this action, and that order doesn't need to go to court. So the police can take the action immediately, and the child can stay in the hospital, and that will for 72 hours and can be renewed. The emergency protection order is the one the social services will ask the court to agree on, and then after that it will continue for 8 days. So this is the difference.
Thank you.
I think 17 he mentioned, do we need to suggest that for the start assessor, what order we need to do it, or just mention we need for doing the strategy meeting? Is that when you
Yeah,
ask?
so I will not go there unless there is a struggle in the scenario. Yeah.
I had a question. Thank you very much, Maha. It was very useful.
No problem. Yeah.
Just in terms of the clinical management, how far are we expected to go? Like, you know, if there's a medical situation, are we meant to go through the whole management of that? I think it's not clear to me.
Yeah, so what I want to hear from you that you read that and you are concerned about it. This child has bronchiolitis, he needs oxygen, and he has a bruise. You know this is the safeguarding station. You concentrated on the bruise and you ignored completely the need of the oxygen. So this is, I just want you to understand the priority of your patient. So you need to concentrate on what you need to manage first, at least acknowledge it, and then proceed with the safeguarding part. This girl, 13 years old, brought unconscious, and you will, the first thing you will say, I will discuss with the social team. But she is unconscious. She could be comatose. There should be a head injury. There should be could be an intracranial hemorrhage. So you need to concentrate on the acute thing. Don't go in details, but acknowledge that you understand the acute situation needs to be managed first before proceeding with safeguarding, if that makes sense.
Yes, it does. Thank you very much.
No problem. All right. Thank you very much.
Thank you so much.
I hope that's useful.
Yeah,
No,
definitely. Thank you so much.
Thank you.
Thank you so much.
I think on the same topic that all essential we need it for all as a pediatric. There is a lot of comment in the chat. One from Muhammad Usman. He just advised for all use the safeguarding hat as one of thinking hat while answering all scenario. As is his start, he had a safeguarding concern in a way or another in 5 to 6 scenario, in addition to the safeguarding one.
Yeah. Thank you so much.
And also, Patrick, he just mentioned, don't forget to finish with the teaching. Consider teaching as the same simulation in your department for the safeguarding. And this is all like a nice suggestion. Thank you so much, Maha, again, and thank you everyone for joining us today. Please don't forget to fill the feedback, and it just only take a minute, and it will help us for plan for the better session. And if you have any like a question for the next session, please put it on the feedback, and we can deal with it. And also, this session was recorded for who participated. If you are happy, this will be in the YouTube channel, and you can access it with the previous session also. And see you in the next session. It will be on 17th of May. 17th of May, yes, but we will circulate it soon.
Thank you very much, Ayat, for inviting me.
Thank you very much, Ayat. I just wanted to ask about the other sessions. So is this